gradual onset. These were the reports. They look okay except CRP is high. And this is the X-ray. So should I revise my diagnosis, Dr. Aparna? This is pneumococcal only, ऐसे मैं परेशान हो रहा हूँ.
So the patient was treated with meropenem, right?
The child was treated with the meropenem, azithromycin, amikacin for 2 days, and the child was referred to us on day 3.
Okay. So did get antibiotics for 48 hours, presumably, and has lobar pneumonia. So our first diagnosis obviously would go for strep, given the
Strep pneumonia.
history.
Okay.
And we see the response.
Okay, yes, doctor.
See, I would like to point 2-3 things in this X-ray. You see the right cardiophrenic and claustrophrenic angle. There is some clearing. You see the horizontal fissure. It quite prominent. So likely there is fluid. So first investigation I will do is a POCUS to see if there is fluid, if there is empyema. If possible, if at all, then I will drain and I will test it. But strepto is a cause, could be. But again, I would like to keep staph also in mind. So rather than azithromycin or amikacin, maybe a staph coverage warrants this type of X-ray.
But meropenem will be also covering staph. But we shouldn't be, for the sake of antimicrobial stewardship, should not be giving high-end antibiotics.
Just
Aji, POCUS expert.
Good point, right? In this type of patient, I would like to look for the, suppose X-ray was done a day before, there can be rapid evolving effusion. Also, there can be necrosis. Now, POCUS, if you do ultrasound, in consolidation, you can point out necrosis.
Necrosis also.
And so, in this type of patient, of course, it looks like first goes streptococcal. But if you find good patch and not a good effusion, a good amount of effusion, mycoplasma could be the cause. Mycoplasma, there will be less effusion and less lymphadenopathy as compared to streptococcal, and cough is more dominating, and also in 26% extrapulmonary symptom.
Okay, now patient is febrile, stable after we saw after admission. Respiratory rate is okay, heart rate is 110, SpO2 is 94. Cause, it could be pneumococcal, but the duration of illness goes against it. It could be influenza with secondary infection. We have seen recently in influenza B, we have seen influenza B with MSSA, blood culture having MSSA. And they are presenting like this picture. Adenovirus pneumonia, it could be mycoplasma, it could be mycoplasma co-infection. Now was being treated with the meropenem, azithromycin, amikacin. And somehow, are you happy with the treatment, Dr. Aparna?
Not really. This is a community-acquired pneumonia, and we know our first-line treatment wouldn't be meropenem to go to treatment. It would be, so we would cover basically the common organisms at strep pneumo and staph. So ceftriaxone that is why we pick up ceftriaxone, which covers both gram-positive and negative,
Yes,
including MSSA. Azithromycin, yes. I mean, actually no for this case of lobar pneumonia.
Already received for 2 days.
Yeah. So, but amikacin, I don't see any role. Mero and Amica.
Why Amica in lung?
Yeah.
You give Amica for lung.
I don't understand
don't give
the use
amikacin
of
for lungs.
amikacin.
It's hardly secreted in the parenchymal tissue.
And moreover,
Unless it is a gram-negative infection, then you may consider.
just another, moreover, amikacin is a second-line ATT, so we need to really be cautious
okay.
about using Amica.
Okay, so I think our experts are okay with ceftriaxone, azithromycin. That's right? Okay. Now IgM plasma is negative. This child has already received, because on day of admission the child had also received azithromycin, 3 days. Should we stop azithromycin, Dr. Agarwal?
No, we like to continue for a complete 5 days.
5 days kar dete hain, let's not create a confusion.
And the reason is sometimes this IgM negative doesn't gives a confirmatory diagnosis that mycoplasma is negative.
Okay.
Because the blood sample was taken on the 7th day and the IgM antibody starts appearing after 7th to 9th day.
Okay.
So it can be
It's
false
better to
negative
complete
also.
the course.
Better to complete the course.
Okay, great idea. Now patient is better on azithromycin, ceftriaxone, and now the patient got tachypnea and fever soon after we stopped azithromycin. क्या करें जी अब? We'll run. Okay. Soon after stopping this azithromycin, the patient has become sicker, fever is 101, there is still no tachypnea, and on next day this is high grade fever, some tachypnea, saturation is 90%, oxygen started. What should I do? Yes, Dr. Dhiren, jaldi se bata do.
मेरे को लगा
Anyone,
वो कर रहे थे
anyone
ना
should
treat-
take. Dr.
I
Parna, आप
think,
बताते जाओ.
I think repeat X-ray and focus, that will give us an answer. And azithromycin, even the half-life of azithromycin is up to 54 hours, so that is no relation that you stopped and effect. has
Okay, okay, okay. So, okay, let's wait. And in the meantime, because the patient has worsened, we did ultrasound as you suggested. There's no empyema or no fluid in the pleural cavity. Complicated pneumonia, there was no suggestion. But anyway, we'll plan if the child doesn't recover in next 2-3 days, we'll do CT. Bug is not covered with ceftriaxone, azithromycin. This is one possibility. And the second possibility is we are dealing with something resistant. Okay, so X-ray is almost same, although the patient has worsened.
No, sir, there is much difference. The angles are, you looks like there is a effusion. On your slide, you said there is a pleural effusion.
Ultrasound, chest, no fluid.
ओके इससे पहले वाली स्लाइड में था
देख लो,
ये नहीं,
पीछे
नहीं,
वाली
आगे-
स्लाइड
आगे- आगे था
ये देखो.
नहीं नहीं इसमें तो लग रहा है सर इफ्यूजन आ गया है एक्सरे में लग रहा है इफ्यूजन आ
The
गया
ultrasound is
एज
none.
कंपेयर टू द प्रीवियस
Next is this, it's almost same. This is the next.
इसमें तो लग रहा है सर नहीं
कर चुके हैं अल्ट्रासाउंड.
नहीं है अच्छा
Chalo, okay. Anyway, now the counts have increased, 17,800. DLC is 84% polymorphs, CRP is 162. Anyway, I'll run through. We added vancomycin and no response, fever pattern is same, high grade tachypnea, now respiratory distress. The wards where there was a discussion, most possibly we are dealing with something mixed infection and we have to do something else. We did blood culture again, which was done after second blood culture, it became sterile. The repeat XHS you have seen, TST was negative, CT chest we did, and we'll show you the CT chest. And we planned for bronchoscopy, and we thought we will do echo also. And to our horror, whenever we saw the X-ray next day, we found there is a bilateral pneumonia now.
ग्राउंड ग्लासिंग लुक्स लाइक
There's a bilateral pneumonia now. So that was really worrying. And then it's a progressive course, bilateral pneumonia, fever is continuing for last 2 weeks, and for last 7 days plus 2 days of antibiotics, almost means 2 days in the last nursing home, he has received antibiotics for 9 days and absolutely no improvement. Blood culture is sterile. The patient is currently on meropenem, vancomycin, and the last nursing home is vindicated. And then this is the CT, and Dr. Dhiren, you are expert on CT. You can see bilateral pneumonias, okay? And then, anyway, we did sputum, GA, gene expert, negative, and lung puncture. I want to know, Dr. Dhiren, I think there's one adult physician, I think pulmonologist also sitting in the gathering, very well known Dr. Rajesh Chawla. I've done several COVID webinars with him. ये lung puncture outdated क्यों हो गया ये? It used to be a very good test. See this paper. They did needle aspiration in as many as 543 patients. 60% में almost they could get the bug. And there was hardly any pneumothorax in these cases.
I think with the availability of safer things like bronchoscopy.
No,
and
we are doing in a
MRI,
non-responding
Right,
pneumonia.
and
I'm not talking of ethical issues because
No.
in a community-acquired pneumonia, I'm
I mean
not
to
thinking
say
of.
it
We can discuss later on anyway,
Yeah.
because there's hardly any time. So what happened was the patient worsened and hemoglobin came down to 7, TLC 24,000. We thought the child is becoming sicker. That's the reason of fall of hemoglobin. And we did again investigated and we found something very interesting. There's an abnormal clumping of RBC on the peripheral smear. There is blood sample was sent for grouping, cross-matching. And the blood bank told me, Doctor Sahab, बहुत मुश्किल हो रही है करने में.
resistant
I said, I've got a
mycoplasma.
diagnosis. Then she
Resistant
told me,
mycoplasma.
Dr. Rita told me, Doctor Sahab, मुझे बड़ी मुश्किल हो रही है grouping cross matching में. मैंने कहा, I've got a diagnosis. And the diagnosis is mycoplasma.
Yeah.
So IgM mycoplasma was positive this
In fact,
time.
I was about to comment
And,
that in today's era, resistant mycoplasma is happening.
Absolutely.
And doxycycline, we are giving doxy. And
Okay.
probably post-COVID, your azithromycin
Now cutting
is
the story
not
within
working.
half minute, this is mycoplasma, IgM became positive, and there's a, I think, good number of cases investigated in Chennai. They said there's no resistance of mycoplasma to azithromycin. Now I wanted to, I think, escalate to either of the two. So I wanted to escalate to levoflox or minocycline, or we could do to doxycycline, but we decided to give levofloxacin. Patient improved in 2 days. And when to give steroids? There are a lot of Chinese paper which tell us if the LDH and ferritin is rising a lot. These are the groups you should be giving steroids. And the patient improved on levoflox, and this is the X-ray. And thank you very much. I stop here. Sorry, panelists, there was no choice except to run through.
So a very interesting case on mycoplasma. I would also like to add that mycoplasma also has another entity called MIRMs, that is mycoplasma-induced rash and mucositis, which looks like SJS, like Stephen
Yes.
Johnson. And so the presentation of mycoplasma